The next presenter is Dr. Adrian Park, who it's a little difficult for me to introduce him for a few reasons. Primarily because I've worked with him for a number of years and I'm extremely close to him. So a lot of times I take him for granted in terms of what all he's done, but Dr. Park at a very high level is one of the pioneers of minimally invasive surgery. He is chairman of surgery at Arundel Medical Center out of Annapolis, Maryland, and has been chair at Dalhousie in Halifax in Canada, and vice chair at University of Maryland, and has a very distinguished career within surgery. And I could go on and on for a while, so I hope you forgive me for not going through it. But he's going to come up and he's going to give us a rather interesting talk from a surgeon's perspective. He has a lot of experience in underserved countries, and one thing I will say is this: he's written what a lot of folks consider the definitive text in the delivery of surgery in underserved areas. So that, plus his technological background, has a lot of meaning for us. So without further ado, Dr. Park.
Well, thanks very much, Ivan. It really is a great pleasure to be here and to be able to share some thoughts with you. I do kind of live in a couple of worlds. The area of surgery that I practice is very technologically dependent, so I take for granted every day this technology, or every week in the operating room, and yet I've spent a lot of my time and outside of my day job in the arena of global surgery and surgery in the developing world. And I will tell you, it's really a pleasure to come to a conference like this. I don't normally come to this kind of conference, and to hear of the advances in technology and to be reminded and maybe even a little convicted that in medicine and in surgery, we really lag. As you will see in a few minutes, we really lag in terms of the adoption of these technologies to the detriment of our patients, I would say. So what I would, we'll see if our little clicker system works here. Do I need a line of sight to my laptop? Okay, let's try it again. There we go. Good. Okay, so I'm just going to talk very briefly in the few minutes that we have. I want to introduce you just briefly to the concept of global surgery and what we increasingly call the neglected surgical patient, just a little bit of demographics on that. I want to talk to you about essential surgery and the context or the lens through which I have been engaged in this work is in sub-Saharan Africa. So I've done some work in Asia, so my comments hopefully you'll find of interest, but they may not have immediate bearing to the situation in India, but there are certainly principles at play between what's going on in sub-Saharan Africa right now and here in India. I want to talk about the promise of technology. It's far from being realized. I want to talk about some high-tech and low-tech potential solutions. I want to talk about high cost and low cost, and a little bit about what the barriers to care and to adoption are going to be. You may just have to hit the thing. Okay. I want to talk about really the exploding role of telehealth, and a lot of people are talking about that, and I think this is one of the takeaways from this conference. A little bit about digital surgery, and then we'll talk about the way forward in the few minutes that we have. Global surgery is kind of defined by various folks in various ways, but I think one of the most helpful ones is this quote that came out of JAMA recently. It was from the presidential address at the Pacific Surgical Association. It really is about the art and science of surgical practice in pursuit of the best outcomes for our patients, through the dealing with the mitigation of the inequity to access of that care to patients, all people around the globe. So that's, in the broadest terms, what we're speaking about in terms of global surgery. Back. Okay. So, and this just gives you a sense, when you look at the darker red, this isn't going to work, but the darker red is back, please. Forward, there. So the darker red is and I don't think I have a pointer that works here. The darker red is the portion of the globe where access to surgery is more difficult and more limited. And this is just a different way of stating the poorest third of the world's population only gets about 6% of the resources for care. So tremendous maldistribution of healthcare resources for the lowest socioeconomic levels of society. This is some interesting data that I think people don't really recognize, and that is that for years and years and years, if you were involved in surgery or trying to bring surgery in areas of sub-Saharan Africa, the sense was surgery is a luxury. We can't even talk about surgery now. We have to manage the communicable diseases. So surgery is a luxury for wealthier nations, wealthier people. Well, it's just not the case anymore. You can see here in graphical form the burden of illness, of surgically correctable disease, and how now it has so far eclipsed that of TB, malaria, AIDS in terms of burden of illness. This is surgically correctable disease. And here's an interesting slide too that I like to point out, and this is when I've been talking with industry over these many years and trying to say you need to invest in the developing world and the neglected surgical patient, it's the right thing to do, and now more and more I'm saying it's really stupid business to not be investing in this huge market, because I think a lot of people are now realizing when you look at the separation of these curves, when you look at the burden of illness, not just the burden of illness, the economic burden, the anticipated economic burden of not dealing with surgically correctable illness is calculated up to about $12 trillion. So these dealing with these illnesses, providing surgical care and capabilities to all of the world's population is no longer just the right thing to do. It is foolish business not to be providing this care. 4 years ago at the WHO, there was a very important resolution from the WHO, 68.15, that's really started to change the world in terms of how we view access to surgical care. No longer is this simply the domain of the wealthy. This really needs to be viewed as accessible to all of humanity. And although this wasn't a resolution, 68.15 in the WHO basically said that access to safe surgical, obstetric, trauma, and anesthetic care has to be viewed as an indispensable part of universal health care. And so this was one of the first times that this really became part of the conversation and could start to influence policy all around the world. At the same time, a publication, an effort called the Lancet Commission on Surgery came out in 2015 as well. And the points there are almost more illustrative and easier to get your head around. So 5 billion of the 7 million people on this planet have no access to safe or affordable surgical, obstetric, trauma, and anesthetic care at present. You can see in low and middle income countries the immediate need, 140 million patients in need of surgery. You can see that folks in all countries face the prospect of financial catastrophe just simply by trying to have access to surgical care. And obviously, this is just not sustainable nor acceptable. And so the concept that surgery has to be seen as an indivisible, indispensable part of healthcare is a new way that we have to think. It can no longer simply be in the domain of the rich. This is a shameless plug. This is the book that Ivan was talking about. Happy to talk to you more about it. Ray Price and I put this out a year or so ago, and it covers a lot of these concepts. So I make the point that India is not unlike the USA in many ways when it comes to access and delivery of healthcare. Both of our countries have the equivalent of first world, high-income country type care, and both of our countries have low and middle income levels of care. A very inhomogeneous distribution of access to surgical care within both our countries. So the context, I say, I wanted to give you a little bit of the demographics as the background. I want to talk a little bit about the neglected surgical patient in the context of sub-Saharan Africa, and then we'll talk about essential surgery and how some of these technologies we're looking to harness, some low-tech, some high-tech, looking to harness to address the needs of our patients. So in Africa now we're looking, we speak in this world often in terms of DALYs or disability adjusted life years, and so motor vehicle collisions by next year are going to account for about 10 million DALYs in sub-Saharan Africa. Of 47 countries within sub-Saharan Africa, 38 don't meet the current WHO standards in terms of healthcare providers per unit population. It's a fairly dire situation. In many places, the overall access in sub-Saharan Africa is about 1 to 100,000, one surgeon per 100,000 unit of population, and in some countries that goes up to one surgeon per 2 or 2.5 million unit of population. And I think, as is the case here in India, there is a tremendous concentration of surgeons and surgical care in urban areas, and in most developing countries, the populations are far more distributed than in some of the Western countries, and there's a far more rural density of population. These patients are not, their care is not being addressed. Essential surgical care, we'll talk about for a minute, and actually essential surgical care actually means something. And what it means changes just slightly in various discussions, but it speaks to several categories of care that all patients, all people around the world should have access to. And in some jurisdictions that changes a little bit, but it really has to speak to if a patient presents in obstructed labor, or for another reason needs a C-section, they should have access to a C-section. If a patient has what we call an acute abdomen, some acute process that is surgically correctable in their abdomen, whether it's an abscess or an acute appendicitis, the surgical treatment for which is fairly clear and from which patients recover and then become productive members back into society, they should have access to that care as opposed to succumbing to that care, that problem, or being disabled for life. If patients have long bone fractures, that arms, so humerus, femurs, things like that, that can be dealt with, and if dealt with expeditiously and appropriately, return those people to being productive members of society. All people should have access to those types of care. There's some discussion around the edges of what dental care, et cetera, should be included in essential surgical care. But the issue when we talk about essential surgical care is that even if we deem that this should be available to everybody now, there simply are not the providers, the trained providers, to make available that care. And so in many countries, particularly in sub-Saharan Africa, we talk about NPCs, non-physician clinicians who have been trained. Treating hernias is another type of essential surgical care. These are usually fairly straightforwardly surgically correctable problems that can then return people back to productive roles in society. And in many countries in sub-Saharan Africa, acute appendicitis, hernia care is delivered by non-physician clinicians. In some countries, prostatectomies, craniotomies, even cataract surgery is delivered by non-physician clinicians. And again, there's an awful lot of discussion about appropriate boundaries, safety of this, the trade-offs between appropriate training and access to care. Much to be sorted out with this. There are very limited studies that suggest that immediate access to care is as important as the person delivering it. I think we're going to find out in the future that we do need well-trained, well-supervised, overseen providers. But I just wanted to introduce you briefly to the concept of essential surgical care because this has to be distributed. The patients have to have access to this close to where they suffer from the illness. They cannot be transported back to major urban centers to deal with this. I've been involved with an organization called PACS for many years, almost since its inception 20 years ago. This is a faith-based organization, and our vision with this organization was to train surgeons in Africa to Western standards to stay in Africa. Many organizations and individuals over the years have felt the need to contribute to the dearth, the lack of providers where the care is most needed, and then unintentionally contribute to a national brain drain. So bring patients from some of these nations to the West, to Britain, to France, to the US, to Canada, and then the best and brightest of these countries don't return. So with PACS, we did not want to do that. We wanted to train people on site, to stay on site, to look after the folks we were training them to look after. So we have about 13 or 14 training programs across 11 countries in East, Central, and West Africa. And the thing probably I'm most proud about with this organization, this is where our alum go. Our alum stay on the continent, again, distributed across East, Central, and West Africa. And I think this is increasingly, to meet the need of the essential surgery requirements and others, we have to bring the care where the care is provided. So here's just one model of how that works. And within PACS, we've been able to do some cool things. So this is a hospital deep really in the jungle in Gabon, which is Western Central Africa. And we were able to get industry to donate the equivalent of what we call a lap or an endosuite. So we're able to do minimally invasive surgery in a very remote area. And we were also able to bring training. So this is training for what's called the Fundamentals of Laparoscopic Surgery, FLS. It's a key component of every surgeon's training in the West. And we were able to bring this and have our residents in a very remote place start training with local simulators in Gabon and Bongolo. Now, again, just moving quickly through this, I'm going to come back again in a minute to the concept of simulation and telesimulation, just talking about some low-tech, low-cost solutions to bringing care to the neglected surgical patient. So one of the things we learned in Gabon, in Bongolo, was that, so normally for laparoscopy, you insufflate to do the surgery with CO2, the gas CO2. And that's the standard and the safe thing, and we've not used air to insufflate, room air to insufflate, for a few reasons, mostly out of ignorance and because we didn't want to risk medical legal problems. Well, when we put this setup in Bongolo, we quickly ran out of CO2, and we realized we were not going to have a regular supply of CO2, so we went about saying, well, what about just using air? We operate in air all the time, and patients don't explode and do things like that. So maybe we could use filtered air. The short of it was that we now have the world's largest experience with air laparoscopy. We've published this, and this was a very local innovation because of the necessity of running out of CO2. So again, here's a technology, a low-tech solution that is made available to people in a very remote place. This has nothing to do necessarily with surgery, but I love the concept of the Lifestraw. I think a lot of you are familiar with it. Again, a low-tech, low-cost solution that affects health significantly. I want to show you another low-tech solution to the neglected surgical patient. This is a dear friend of mine. This speaks to the problem of esophageal cancer in East Africa, in Kenya in particular. So that's endemic to Kenya for a variety of reasons, and most patients present with esophageal cancer that's very advanced. They can't swallow, they're in pain, they become cachectic and starve to death, and then they end up not being able to swallow their own saliva. It's a terrible, terrible way to die. So in the West, for a non-resectable esophageal cancer, we put stents in. And when you put a stent in the esophagus to bypass the esophageal cancer, the patients don't survive, but it's a far more comfortable and controlled and good passage, if you would. Well, these cost, as you might imagine, many thousands of dollars, and unless they're donated on a regular basis, they're inaccessible to most people. Pankaj Jani is a Kenyan of Indian descent and a professor of surgery in Nairobi, and he brings these patients from Kenyatta Hospital to his clinic on his nickel. He does this himself. And he brings these patients in, and these are patients that come from the remote reaches of the country, obstructed with esophageal cancer, miserable way to die. They're sent away from their villages. They are ostracized, and they can't even swallow their spit. And what Pankaj will do is he will take equipment to dilate that esophageal cancer. This is equipment that we stopped using many years ago that he got donated to him. And then he brings these patients, he finds them, brings them to his clinic at his expense. He will dilate these cancers, and then there's no stent that any of these patients can afford. So he found, I forget what part of India he's from his family's here. He found some guy near his village who will simply make these little silastic stents for pennies a go. He brings a couple of suitcases back. He comes to India several times a year, brings these suitcases of these very cheap silastic plastic stents, and then he brings them back and he uses them on these patients. So here's one of these stents. He's dilated this stent, and this patient now has a stent. It's been placed. He's not going to survive his esophageal cancer, but he is going to be able to die with dignity, return to his village, get his affairs in order, and have access to care that he would otherwise never have. So these are innovative, low-tech, low-cost solutions. I just want you to be aware that we have to be so creative when we're looking at how we access and bring care to the neglected surgical patient. They're also high-tech. Here's a high-tech, low-cost solution. This is the emergence or development of a very inexpensive and essentially disposable laparoscope. So the laparoscopes that we use to do minimally invasive surgery, minimal access surgery, are tens of thousands of dollars, and usually available only in urban centers. So this is the Xenoscope, developed out of the University of Utah. They have a wonderful program, and they put on a conference that's called Extreme Affordability. So creating a technology that is available really to the masses. And this Xenoscope can be produced at about $100 a pop. So this can connect to your laptop or your tablet or whatever. So you don't need tens of thousands of dollars worth of technology. You can bring a $100 Xenoscope and do surgery connected to your laptop, and all of a sudden the neglected surgical patient has access to minimally invasive procedures. And this has been written up in the Wall Street Journal. There are also, so we've talked about low-tech, low-cost solutions for the neglected surgical patient. We've talked about high-tech, low-cost, and I'm going to talk to you briefly now in the last few minutes about high-tech. And right now it's not low cost, but hopefully it will be at some point. So now, how do we bring connectivity to reach these neglected surgical patients? So the idea, you've heard an awful lot of discussion about artificial intelligence and bringing that into the medical realm. And as you might imagine, there's an awful lot that we have to be very thoughtful about and very careful about. Standards have to be really agreed upon before we say, okay, we can hand over your mom or your father or your son to a doctor bot, a robo-doctor. We have to be very clear on this. This isn't going to play now, but if you guys can go look this up, look up Google Duplex. And this is natural language AI. This recording is essentially of a robot calling a human to make a restaurant booking in San Francisco. And the person who answered the phone at the restaurant had no idea that they weren't talking to another human. They thought they were talking to a human. They were essentially talking to AI in natural language. And so these capabilities exist. In fact, when you hear this for the first time, it's so creepy that several folks, next slide. So go back one. Was that me or you? So the concept of not knowing whether you're talking to a human or a bot has creeped a bunch of folks out, and so Google Duplex had to take a step back. In fact, in California, next, just tap it again, please. So that Google had to step down, and when Duplex is actually talking to somebody, it has to identify itself as not a human, and there are now California laws that require bots to identify themselves as non-human. Such is the advance in terms of natural language interaction with these AI platforms that we have to be careful. This is an interesting use of it. This is a project that's sponsored by an organization called X2AI. This is a young boy, Syrian refugee in a camp in Lebanon, and he's using a laptop and a device that's called Kareem. And Kareem is basically AI that can interact in Arabic with this young boy, trying to help him through the stress and the trauma of his life. And again, it's far from perfect, but in the camp where he is, there's nothing else. And there are other examples in the mental health industry of bringing AI in non-human interactivity with patients. And so, again, not much in the way of surgery at this point, but there is no question that the inroads that AI is making in and the use of natural language is changing the game. In the final couple of minutes, I just want to talk about the importance of connectivity and the role of telesimulation. So this is work out of the University of Toronto. Alo Kranick has been doing this work for some time, and the idea is he was trying to work with a medical center in Botswana to help their surgeons get through this FLS, the Fundamentals in Laparoscopic Surgery training. And so what they did this was about eight years ago, and so the technology, the speeds were far inferior to what we find today, but it's a fairly basic setup, and they really demonstrated the benefit of telesimulation by this very small experiment. They had 16 surgeons in 2 cities in Botswana, 8 in each city, and they put them through the FLS curriculum, and they had to work 2 hours a week for 8 weeks, and in one of the groups there was telesimulation that was available to them. In the other group, it was just simply the curriculum like most surgeons have to go through. And this is what they found. 100% of the patients of the surgeons who had access to telesimulation passed their FLS, and only a third who had no access to telesimulation passed FLS. So the impact that we suspect shown very nicely in this small study of telesimulation. Of course, we then move on to the concept of telementoring. Various of us have used this concept. I think you're going to see a demonstration today of telementoring. This is some early work. And even in Canada, a very wealthy, high-income country, has a very distributed population. And so the University of Toronto is using telementoring from Toronto to impact some of the very northern health centers to help with training and delivery of care. There's an organization called In Touch Health, founded by a serial innovator by the name of Yulan Wang. And Yulan Wang, I would really have to say, is the world's leading authority on telehealth. He founded a company called In Touch Health, and they began an initiative, a charitable work called the World Telehealth Initiative, to basically bring telehealth to the most distributed of populations, the most remote of populations. And what World Telehealth does essentially brings peer-to-peer teaching, surgical mentoring, clinical consultations, and synchronous high acuity use case type work. And they're growing this work around the globe. But here's a really interesting and, to my view, fairly profound picture of the application of telementoring. So if you look at the yellow, data on top, those are the number of cases that were done. This is a Malawi clinic. This is dealing with a very serious problem of a vesicovaginal fistula in Malawi. It's unfortunately all too common across sub-Saharan Africa. But with the yellow curve, this is the number of cases that were done per unit time, per month, or whatever it was, by visiting surgeons. This is surgeons who had to come in to provide this care. Then what happened was they started training some local providers, and the blue curve was the number of telementoring sessions that were required to get the red curve, which is the providers, up to the level of care provided now. So again, I can't show you. You can see where the red and the yellow curves now meet. So now, on the basis of the use of telementoring and telementoring that WTI supported, now there are native indigenous providers able to provide fistula care at the rate that required visiting surgeons to come in. So this is now a sustained solution showing the benefit of telementoring. And again, you know, as we look at where this is heading, the connectivity is key, the analytics is the next piece, and of course, the intelligence to that. Now, there is a tremendous entrance now of all the major tech companies into this, into the field of healthcare. You can see here the number, the venture funding and all the major players who you'll recognize there, the degree to which consumers are engaged, 300,000 apps, healthcare-based apps for mobile phones now, and 80% of mobile phone users in the U.S. use them to access care. And that care can be for preventive medicine issues, chronic care, for diagnoses, and even for episodic care. So the importance of connectivity and the sophistication, the speed, the flexibility is only going to be increasingly important, not just to patients in urban areas, but to patients in very distributed locales as well. And right now, we're at the stage of just of the sensors everywhere. We obviously want to get through to the point of doing something in terms of processing the data that is derived, that comes from these sensors, and then using machine learning to further render artificial intelligence applications from those. So we're very much in box one or bucket one at this point, but the potential to bring this in to surgical care, it's just a very exciting time. And this, when we talk about now, we talk about digital surgery. You know, people think it's all about robotics, and the robot right now, for the most part, is it's a sophisticated, very smart technology, but it's master-slave. And we're looking increasingly to getting into these sensors, getting into augmented gestures, augmented movement, augmented visualization, and bringing more intelligent applications at the far end. So that's what digital surgery, we're at its absolute outset now, but it's very exciting where this is going to head in the next 5 years. Surgery is going to be transformed within the next decade. And so just simply Dr. Tedros was already invoked today, and I think it's important just to remember as we close this out that surgical obstetric anesthesia care is an essential part of every healthcare system. You cannot achieve universal healthcare unless people have access to this. And there are barriers. Excuse me, most of them are cost, but that can come down. Connectivity and culture in terms of access and cultural acceptance of this. There's not much use in the developing world of the electronic medical record. Most of us in the West hate it, but grudgingly admit the impact it has on patient safety and quality of care, and we have to start having that penetrate in the developing world as well. We really don't need the high-end, decked out Mercedes right now in the technology that we need. We need reliable Tatas. We need reliable energy sources, and we need robust technology, not the really optioned out stuff. But I do think, as I've said, surgery is going to be transformed in the next decade, and the promise of technology to bridge the chasm between the haves and the have-nots of surgery is now more palpably close than ever before. And I thank you for your attention.